think we're good. So I think we'll be able to go ahead and start then. So Dr. Rosen, please take it away. He's going to be talking today about, was raffling. I heard at AGM was raffling things off from coming here.
Yeah.
Do we have more QR codes? Wisconsin can pull in a few more gift certificates.
I don't know. I feel like Wisconsin's got like, it's like the fixes in or something like that from the Wisconsin perspective.
I think Manish fixed it.
We need cheesehead stuff and everything like that.
Yeah.
So awesome. So Dr. Rosen is going to be talking about the impact of the Vulnerable Elder Protection Team, the VEPT team, as an ED-based multidisciplinary elder abuse intervention. So take it away, Dr. Rosen.
Thanks very much, Dr. Michelle. My name is Tony Rosen, and as you can see, I'm presenting on behalf of many colleagues inside and outside of our institution. No financial conflicts of interest to disclose. We're certainly lucky to be the beneficiaries of funding from several agencies, federal and other. Elder abuse. Unfortunately, elder abuse is common and has serious consequences. We think that as many as 10% of older adults experience abuse or neglect each year, and this victimization dramatically increases mortality. It may triple mortality and increases other important medical outcomes such as nursing home placement, dementia, depression, and exacerbation of chronic illness. And even though elder abuse is really very uncommonly identified, the ED visit may provide a really unique opportunity to identify elder abuse and to initiate intervention. But the limited research that we have suggests that emergency providers rarely recognize it and almost never report it. And this is probably at least partially due to significant disincentives. After all, we're ER doctors. We don't have time to conduct a thorough evaluation for elder abuse. And also, there isn't a clear protocol in most clinical settings for a streamlined response if we identify the concern for abuse, neglect, or exploitation. And so that's what we recognized when we designed something that we call the VEPT. It's a first of its kind, ED-based, multidisciplinary team, the Vulnerable Elder Protection Team. It's a consultation service. It involves an ED provider and a social worker available 24/7 because we're ER folks to assess, treat, and ensure the safety of elder abuse and neglect victims while also collecting evidence when appropriate and working closely with the authorities. We designed it, as you can see in the top right, to be kind of like a button. If you're concerned, just press the button. And we were hoping that by designing this, we would increase identification among our colleagues and also decrease burden on them, because all they needed to do if they were concerned was activate us and we would take next steps. And if you're saying to yourself, gee, this sounds sort of familiar to me, we designed our program and modeled it after the child protection teams that exist in most large emergency departments that provide an analogous set of functions for child protection when we're concerned about potential child abuse in our EDs. And so what was the objective of the research that I'm going to report on today? It was to examine the impact of our VEPT program in the first 2 years after launch. And our methods, we launched our program in a large urban academic medical center at Cornell on the east side of Manhattan, New York City, on the 3rd of April 2017. And we tracked the characteristics of our team's assessment, interventions, and outcomes for each case activation for the following 2 years. And we also administered written surveys to attendings, nurse practitioners, PAs, and nurses 1 year after launch to assess their perception of the program's impact. So we looked both at the actual impact and its perception. So what happened? Well, our VEP team was activated and provided consultation and care to 200 patients, almost 2 consultations each week during our first 2 years of operation. And as you can see, we were consulted for virtually every type of mistreatment, physical abuse and neglect most commonly, but even sexual abuse. And as is consistent with existing literature, more than half of the patients that we evaluated, we were evaluating them and concerned about the potential for multiple types of abuse occurring concurrently. And so after we evaluated patients, we assessed their risk and our level of concern for mistreatment at high, moderate, or low. And you can see here that 62% of the patients had high or moderate concern for mistreatment. And so we felt that this was actually very reassuring. Similar to child abuse, if every time we're consulted, we're concerned, we would probably be getting consulted too infrequently. And so this shows that our colleagues were using us for a breadth of possibilities, and we were also able to sort out cases that we would be concerned about after a full evaluation from those that we would not. But for us to evaluate impact, we really wanted to focus on what were the outcomes for the patients for whom we had high or moderate concern for mistreatment after our evaluation, the ones where we really felt like an intervention might be necessary. And we looked at a lot of different interventions, but the thing that we focused on was living situation after discharge. After all, the ED and hospital have important and a broad range of resources available 24 hours a day. And what we found was that we were able to change the living situation of more than half of the patients for whom we had high or moderate concern. 14% we were able to discharge to an elder abuse shelter. There are actually 2 elder abuse shelters in New York City. And among the patients that we discharged into the same home situation, or that were discharged after their hospital admission into the same home situation, we added, or our program and the hospital was able to add new or additional home services to an additional 22%. So if you look at this, 75% of the patients had a change to their living or housing situation or new and additional home services. And for those of you that are focused from the perspective of hospital leadership, only 4% of these patients since returned to the ED for a mistreatment-related issue. So these were patients that were often cycling through the ER repeatedly. And by our interventions, we were able to hopefully change that, at least for many patients. The results of our surveys, 83% of our provider colleagues reported that the existence of the VEP team increased the frequency with which they consider or assess for elder mistreatment. 38% reported that they actually use the program themselves frequently. And hopefully for us, at least most encouraging, 94% reporting believing that there was merit in establishing a VEP program in other EDs. And we have actually already begun expanding this program to other EDs within our hospital system and looking at telemedicine as a way to expand the program. So in conclusion, VEP was frequently activated. It was acceptable to our provider colleagues, and the interventions often increased safety through changes in living situation and additional home services. We can talk about a lot of other interventions in a larger or longer presentation. Additionally, however, future research is needed to examine longer-term outcomes. After all, these aren't necessarily the only patient-important outcomes, and these are outcomes that are really focused only on the hospitalization, the ED visit, the hospitalization, and the disposition from the ED visit or hospitalization. And it's really much more important, we think, to examine longer-term outcomes, and that's what we're in the process of doing now. So thank you very, very much. I'm certainly happy to take questions, but I also know that we have lots of other presenters, and these are my kids in a pre-COVID period, and we're hoping to be able to do this again very, very soon. Perhaps for all of us in New Orleans next May.
Great. We have a couple of things here. Congrats to your team from Thomas Helmick. He asked, did you get pushback on the cost from admin and leadership on implementation for this? Because it seems like it would be a pretty robust team with only 2 consultations, quote unquote, per week. Was there any pushback on the cost of that for only 2 consultations?
It's a great question. And we actually initially designed this program using a private foundation grant. But we have subsequently built the program into a program that's funded by the New York State Office of Victim Services. So the same programs the same funder that funds our sexual assault forensic nurse examiner teams and our victim intervention program for victims of violence funds this program. And so in fact, our hospital didn't give us pushback because we've been able to separately fund the program entirely. However, we are also looking at because the 2 consultations per week doesn't require a huge resources from our perspective, we've been able to run it without any funding from the hospital.
What would you say is the percentage of the overall number of geriatric patients that received a consultation? Because you said you got 2 consultations per week, but what does that actually look like on the number of patients that you actually see coming through your emergency department?
It's a great question, and it really depends on the number of patients, of course, which has changed, particularly during COVID time. But in general, it's about between 1 and 2%. It's closer to 2%, which is from our perspective very, very different from before us. It was, and in the literature, it's 0.01%. So it's somewhere between 50 and 100 times what we would expect otherwise.
Understood. Another question from Dr. Sutherland was, did the team see them in the ED, i.e. real time, or were they admitted for evaluation on sort of a daytime schedule, or did the VEP team see them after they were admitted?
Great question. And again, I know there's other presenters, and I want, in fact, we managed all three of those scenarios, and I'll add a fourth, which was sometimes we saw them in real time in telehealth. So we recognize that for certain patients, it's important for them to be seen in real time in order to document certain aspects of the physical examination. However, for many patients, we could wait either until morning or until after they were admitted. And we recognize, particularly based on the previous question, that we wanted to not overburden resources. So we are able to respond in the middle of the night, but we aren't typically coming into the hospital in the middle of the night in order to see a patient unless there's unusual circumstances. We tried to balance wanting to be very responsive during ED time with, at the same time, also being able to not devote a huge amount of resources to this so that we could maintain it and expand it, which we've been able to do. So we've actually not only, one of the things that we found was that our ED-based program, the word got around, and so now we've actually expanded our program and we take consults in the hospital as well. And so if a patient is not recognized to be a victim in the emergency department, but ultimately recognized to be a victim 2 or 3 days later for one reason or another, we'll actually see them and follow them through the hospitalization as well. So we've expanded the program. But all these are really great questions and go to the experience that we've had building the program.
Okay. One more question for me was that you had 14% that went to sort of these shelters, and then you had 25% that were quote unquote outside of the realm, sort of saying, of a change. What about the other 40 something percent that were in that big gap? What was the other changes that went into there?
Great question. And it's a couple of things. Some of those patients went to other skilled nursing facilities in a subacute rehab basis or other places other than home. However, a good percentage, and this is one of the things that's important, could have went to another family member's home. One of the things we can do in an ER is if we recognize that a certain situation is unsafe, we can advocate for a different daughter to take the patient into their home, or for someone to come from out of state to take the patient and bring them back to their home. And so those patients were either went to subacute rehab or another skilled nursing facility because under certain circumstances, it was possible that the family was unable to provide the care that the patient needed, or the patient needed rehabilitation services on a short-term or a longer-term basis. And of course, I could talk about that for at much more length. But also there were patients that went to other family members' homes. And I want to add a small piece to that answer, although I know my time is running out, but I want to add another small piece to that answer, which is that's, I think, why we also really want to focus on longer term outcomes, because we recognize that moving a patient from home to a nursing home might increase their short-term safety. And we might be able to say, whoa, we were able to increase the short-term safety. But I'm not sure from a longer term quality of life perspective or from a longer term health perspective that is an ideal intervention. And so we're looking very, very closely now at that to understand what the longer term impact of these interventions is.
That is wonderful. I think I'll give a couple seconds in case anybody wants to jump in for one last oral question. Speak now. Anybody, please? Okay, I think we're good. And then we'll go over to our next speaker, which is Dr. Jacobson, who is going to be talking, sorry about that, I was going to go over it, about a randomized controlled trial of emergency department to home care transitions intervention for community dwelling older adults. And again, this is another AGEM sponsored abstract. So take it away, Dr. Jacobson.
Wonderful. Can you see my slide?
Sure can.
Hey, I've got a lot of screens open. Okay, Thank you very much for that introduction, Philip. Again, my name is Gwen Jacobson, and today I'm going to be describing the results of a randomized controlled trial testing a community paramedic delivered care transitions intervention for older adults following discharge from the emergency department.
Really?
And I have no conflicts of interest to disclose. So adults age 60 and older account for about 20% of all ED encounters in the US, representing 22 million visits annually. These visits are frequently followed by adverse events such as functional and physical decline, delirium, and death. The majority of community-dwelling older patients are discharged directly home. At discharge, patients receive an after-visit summary containing all their post-discharge instructions, including appointments that need to be made with outpatient providers, new medication orders, and short-term treatment plans. Although much of this is reviewed during discharge, the amount and complexity of the information can be overwhelming. As a result, many older adults leave the ED without a complete understanding of their discharge instructions, demonstrating low levels of informational recall. At home, patients and caregivers are once again responsible for managing their health, including all the new orders and treatment plans. This could include making medication changes, obtaining prescriptions, scheduling and attending one or more follow-up appointments, monitoring new or worsening symptoms, and organizing new information. Given the complexity of these self-management activities, it's no surprise that 20 to 25% of older ED patients return within 30 days. Researchers are studying different approaches for improving these care transitions using interventions such as in-person or phone-based coaching or care coordination, suggesting this will lead to better self-management and prevent the need for return ED visits. So the Care Transitions Intervention, or CTI, uses a well-established coaching model for post-discharge self-management support. Intervention content covers medication review, encouraging outpatient follow-up, increasing knowledge of red flag symptoms, use of a personal health record, and health-related goal setting. The CTI was designed for hospital-to-home transitions. However, its effectiveness at improving ED to home transitions was unknown. So to address this question, we conducted a multi-site randomized controlled trial of the CTI, minimally adapted for use following ED discharge and delivered by highly trained community paramedic coaches. We had two hypotheses regarding CTI effectiveness. The primary hypothesis was that patients randomized to the intervention would have lower odds of ED revisits over 30 days compared to those receiving usual care. We also hypothesized that they would exhibit higher performance of the self-management behaviors specifically targeted by the CTI. We conducted this trial at 3 EDs, 2 affiliated with the University of Rochester, New York, and the other affiliated with the University of Wisconsin-Madison. We recruited community-dwelling ED patients who were at least 60 years of age, English-speaking, and were discharged directly home from the ED within 24 hours of arrival. Subjects were excluded if they were actively enrolled in transitional or care management programs, presented primarily with a behavioral problem, or had an ESI of 1. Our analytic approach used bivariate and multivariate logistic regression models, taking both intention to treat and per protocol approaches. All outcomes were treated as binary. Our primary outcome was whether any ED visit occurred within 30 days of discharge. We also assessed if ED visits occurred within 14 days to discern shorter-term effects. We measured 2 types of outpatient follow-up. The first was any in-person visit at a primary or specialty clinic, not including urgent care or labs. The other was electronic communication with the clinic, either by phone or web portal message. At that time, telehealth visits were not offered. Red flag knowledge, self-reported 4 days after discharge, was defined as being able to report any of the red flags listed on the AVS. Medication adherence was also assessed at 4 days and was defined as making all medication changes described on the discharge instructions. Only participants that had red flags or specific medication changes on their AVS were included in those analyses. So this graphic depicts our study design. All older patients presenting during recruitment hours were screened for eligibility, and only those anticipated to be discharged directly home were approached. If patients agreed to participate, they were randomized to either receive the CTI intervention or usual care. Participants not having capacity to consent could defer to an LAR. While in the ED, researchers administered a baseline survey and scheduled times for phone surveys to be conducted at 4 and 30 days after discharge. Phone survey content included red flag knowledge, medication changes, health-related self-efficacy, and satisfaction. And after completion of the participants' 30-day study period, researchers also abstracted clinical data from the EHR to objectively assess healthcare utilization in comorbid conditions. The participants randomized to the CTI received a coach home visit 24 to 72 hours after discharge. During these visits, paramedics used coaching strategies, such as motivational interviewing, to address CTI content and self-management behaviors. These typically lasted about an hour, at which time the coach scheduled a follow-up phone visit for a week later. Participants could receive up to 3 phone visits over the 28-day study, based upon coach's assessment of their need. 1,756 patients were included in our final data set. Participants' average age was 72, 53% were female, over 90% were non-Hispanic white, and roughly 60% had a 4-year college degree. We had reasonably equal distribution of characteristics between the control and treatment conditions. Characteristics that differed with a p-value of less than 0.1 were included as covariates for the error-associated models. 84% of intervention participants scheduled for a home visit actually received one. The most common reasons for participant cancellations included having a conflicting medical appointment, feeling too ill to meet in person, or needing to return to work. Importantly, participants were significantly less likely to have their home visit if they were cognitively impaired or had less than a college degree. So what did we find? Overall, 12.4% of participants revisited the ED at least once during their 30-day study period, with 2.3% returning multiple times. The CTI did not significantly reduce odds of ED revisits using either analytic approach, failing to support our first hypothesis. Interestingly, participants with cognitive impairment had more than twice the odds of revisiting our ED compared to those without impairment. Greater number of comorbidities also predicted ED revisits at both time points, an expected significant contributor to all of our analyses across the board. We saw a significant effect of the CTI on in-person follow-up, as participants who received the intervention were 24% more likely to have an in-person visit in the week following ED discharge. The effect was no longer significant at 30 days. Now, it's a different story for electronic communication. The CTI did not generate significant effects. However, controlling for all other factors, participants who identified as a race other than white and those with less education were significantly less likely to follow up using these methods. Participants receiving the intervention also had significantly higher odds of reporting at least one red flag 4 days after discharge. Above and beyond the positive effects of this intervention, participants with cognitive impairment and those with low health literacy were still significantly less likely to correctly identify any red flags. We found no significant differences in medication adherence, keeping in mind that only 407 participants were included in this analysis. Our findings are consistent with other current research demonstrating that across different designs and formats, post-ED care transitions interventions either had no significant effects on ED revisits or actually resulted in increased ED use over 30 days, with only few exceptions. A recent meta-analysis determined that overall, interventions aimed at improving post-ED care had much greater success at improving outpatient follow-up compared to ED revisits. So why don't interventions like the CTI reduce ED visits? There are at least 4 possible explanations. The first is that both research sites in our study are accountable care organizations, which, due to their integrated structure and allocation of staff for care coordination, could reduce the value of the CTI. Our overall 30-day ED revisit rate of 12.8% was well below those reported elsewhere, possibly due to ACO policies and programs. The second possibility is that our target population was too broad. Some researchers have argued that interventions will only result in reduced ED visits for those at higher risk of return, experiencing care fragmentation, or have certain modifiable risk factors, rather than taking an undifferentiated approach. The third possibility is rooted in the assumption that care transition programs should result in decreased ED revisits for all older adults, without regard to population heterogeneity. Our intervention emphasized the need for patients to understand when to seek emergency care, possibly making them more likely to recognize symptoms and return to the ED. Similarly, during recommended post-ED follow-up visits, clinicians often reevaluate symptoms and sometimes refer patients back to the ED for acute care. But fundamentally, we need to ask whether ED recidivism is the most meaningful outcome to measure. Unplanned revisits frequently involve non-modifiable risk factors or are related to chronic conditions, making them difficult, if not impossible, to prevent. Others are truly necessary to treat acute symptom onset. We need to expand our definition and measurement of successful care transitions outcomes and evaluate programs using those metrics. For instance, new research indicates that patients who return following these kinds of care transition interventions present with less severe symptoms, having been caught early enough to prevent more advanced and more costly inpatient care. We should also consider outcomes such as quality of life, functional status, healthcare costs, and use of allied health services. So improving inpatient follow-up in the week after discharge is particularly relevant for geriatric emergency medicine, where it is best practice to recommend that patients seek prompt follow-up. Given traditionally low rates of post-discharge follow-up by older adults, the CTI has proved useful for facilitating this care continuity. Increases in red flag knowledge also illustrate CTI's potential for improving problematic aspects of the ED discharge process, particularly difficulties understanding and recalling care-related information. Our intervention did not reach all older adults equally, particularly missing those with cognitive impairment and less education. We must attend to these gaps, further refining the program to meet the needs of these groups. And finally, we need to determine which care transitions, interventions, and delivery strategies work best for different types of older adults, rather than trying to engineer interventions aimed at reducing ED revisits for the older adult population as a whole. And we're happy to take questions during this session or through the conference system chat or via email. Thank you.
Perfect. I have a couple of questions from the chat as you're going through there. One of the questions were you looking at same cause ED revisits or all cause ED revisits?
It's a great question. These were all cause ED revisits. It wants me to hit OK. These were all cause ED revisits. We didn't differentiate between ones that were related, as that's a sort of a subjective call.
Understood. The other question was, do you have any ideas on how to integrate something similar into the ED visit itself, without research funding? Because it'd be difficult to make these home visits happen in most places without sort of research funding behind it.
Yeah, and actually, that's also a great question, because that's something that we're wrestling with now. It is wonderful to be able to use resources like community paramedics outside of the ED, but there has to be some sort of connection within the ED in order to get people referred to that program. And so part of that really is integrating some sort of flow from someone who can identify patients in the ED that would most benefit from having a home visit and follow up by a community paramedic coach, and then communicating that need in a HIPAA compliant way to our community paramedic coaches, which in our case were outside of our health system. So there are some barriers with technology that would need to be overcome in order to implement that, and that's on a health system to health system basis. But if we can determine who the right people are that could benefit from this, it would be much easier to screen for that within the ED.
Understood. How did you account for people visiting EDs outside of those 3 candidates / other EDs? Are all of them on a shared EHR or Epic or what?
Yeah, so we tried to narrow our population to start with for people who were just within the health systems, to try to avoid as much of that as possible. During our 4 and 30-day follow-up calls, we asked people if they had returned to the ED, if they had experienced any other type of urgent care, what their care utilization was. And if anything was mentioned that they said occurred outside of the emergency department, then we specifically went and tried to research and look for that information as much as we could get. And there were actually turned out to only be a small handful of them. We have a lot of snowbirds in Madison, and so sometimes people will take off for a while during the winter. But it turns out most people really did stay within our health system, and we were able to obtain information on any other ED visits that they reported.
Understood. Dr. Sutherland also asked, they've tried something similar and no patients wanted home visits from an RN. Do you think that the paramedics are somehow more welcome? And did you encounter this type of resistance in your population of, say, RN versus community paramedic?
We had more resistance to people who just didn't want anybody in their homes, in which case they declined to participate in the study and said that was a reason. And again, that's something we're trying to accommodate now. The community paramedics are perfectly poised to be more welcome within people's homes. They don't see that as being someone in a white coat, someone in the established medical community, and they know paramedics are people who go into lots of different homes. They see people at their worst in their home settings, and people are much more likely to open the door for somebody actually wearing a paramedic uniform. And we made sure that when they went out, our community paramedics were wearing their official uniforms to communicate that.
Gotcha.
Yeah, we didn't ask anybody specifically about whether they would have also done it if it was an RN delivering.
And I think we have 30 seconds for one last question here, which is coming from Chris. One of the complexities in the international geriatric research is unraveling vulnerability inherent to patient physiology and unique disease status from the healthcare system in which they can access care. How would you design future studies like this across healthcare settings to unravel these issues?
Oh, that's a much larger than 30-second question. I would love to have that conversation. We're actually trying to do some of a latent class analysis right now to try to unravel a little bit of that and figure out, because of all the complexities, what those clusters of patients look like. So is there a set of characteristics that might allow us to target certain people for certain types of interventions like this? There are a lot of institutional barriers that differ across healthcare settings and across countries based on the healthcare system. So I would love to have that conversation more with you later.
Unfortunately, that's going to be all the questions that we have. And so next, I think we're going to move over. Thank you, Dr. Jacobson. And I think we're going to move on to Dr. Silva, who's on. Yes?
Yes. Can you hear me?
I can. Sure can. Awesome. Perfect.
Perfect.
Well, we got a strong representation from Wisconsin up in here.
Wait a second.
And Dr. Silva is going to be talking about risk factors for delirium in older adults in emergency department, a systematic review and meta-analysis.
Perfect. Do you see my screen?
Sure do. Got your screen, your camera, and all your slides. You're ready to go.
Perfect. All right. So hello, everyone. My name is Lucas Silva, and I'm a research fellow in the Department of Emergency Medicine at the Mayo Clinic, Rochester in Minnesota. So today I'll present our abstract on risk factors for delirium in older adults in the emergency department. I have no disclosures. Delirium is an acute clinical syndrome characterized by a rapid change in brain function, mainly affecting the ability to focus attention. And some authors actually describe delirium as an acute brain failure. Delirium is common in geriatric hospitalized patients, and approximately 10% of older adults presenting to the emergency department will have delirium. Delirium is associated with several bad outcomes, including but not limited to increased mortality and decreased functionality. So detecting delirium is actually very important. The issue with delirium, however, is that the presentation is often subtle. And there are studies showing that up to 90% of delirium in the ED is actually hypoactive. So instead of agitated, the patient will be instead of agitated, the patient will be quiet, just like this gentleman in the photo. And in this context, we know that emergency department providers miss delirium very often. So with this background in mind, it seems clear that identification of a subset of high-risk patients is paramount for optimizing the delirium screening process in the ED. So perhaps screening only the high-risk people may be a good alternative to screening every single older adult who come in. But we first need to understand a little bit better who are these high-risk patients. So in our study, we had essentially two aims. So first, to identify the most important risk factors for having emergency department delirium among older adults. And second, to identify emergency department-based modifiable risk factors for developing delirium during hospitalization. So in order to achieve those two aims, we performed a systematic review and meta-analysis using very standard procedures. So systematic reviews can be described as the lens through which we see the existing evidence, the existing literature. And they're actually very helpful methodology when so much literature is already published in the topic. So in this systematic review process, we evaluated more than 4,500 reports, and we did all the steps in duplicate, including study selection, data extraction, risk of bias, and the grade assessment. And for those of you who have not heard of grade before, this is an approach that involves consideration of domains beyond risk of bias alone to evaluate the certainty level or the quality level of the evidence. And grade is traditionally done at the outcome level, but in this case, we did for each risk factor. So for every effect estimate for each potential risk factor that we found in our systematic review, we gave one of these 4 levels of certainty about that estimate. And for this abstract specifically that I'm presenting today, we have focused on the risk factors that had a strong association with delirium, defined as having an odds ratio estimate greater than 2. and those who had a label of high level of certainty, meaning that we were very confident that the effect estimate that we found is close to the truth. So for aim number one, we included observational studies of older adults, 65 or older, who presented to the emergency department and were evaluated for ED delirium. And for this, we decided to focus only on those relevant potential risk factors for early identification. So variables like emergency department diagnosis, laboratory, or imaging, they were not considered here because this information is often available after extensive workup and at the end of the ED stay. So these variables, they're not very helpful because the goal here was to identify variables that could flag high-risk patients early on and perhaps to prioritize the screening process. And we also included only studies in which delirium was measured with previously validated diagnostic instruments, such as the CAM or the BCAM, for example. For aim number two, our focus was to identify the modifiable things that we do in the ED that could impact the risk of developing delirium later during hospitalization. And for this, we included observational studies in older adults who were free of delirium in the ED and who were subsequently admitted to the hospital and evaluated for delirium. We then extracted data on the potential ED-based modifiable risk factors to understand their relationship with the development of delirium later during hospitalization. And for this, we also included only studies that use previously validated measures of delirium. So after reviewing more than 4,500 titles and abstracts and more than 200 articles in full text, we ended up including 27 studies that had data of interest on risk factors for ED delirium. There were more than 13,000 geriatric patients in whom delirium was assessed during the ED course, and the prevalence of ED delirium in the studies ranged from 7% to 34.7%. Across these 27 studies, we evaluated 57 potential risk factors for ED delirium, and most of them were not significantly associated with an increased risk of delirium, or they had estimates representing weak associations with moderate to low certainty evidence. So we only found 4 variables with strong associations, defined as an odds ratio estimate greater than 2, where the effect estimate was graded as high certainty using the grade approach. So first, we found after pooling 4 studies and 1,255 patients, that those arriving in the ED from a nursing home have a much higher risk of having delirium in the ED with an odds ratio estimate of 3.45. Second, we found that older patients with any type of cognitive impairment, and here mostly history of documented dementia, have a much higher risk of having delirium in the ED. And we pulled 7 studies here with a total of 2,818 patients, and the odds ratio was estimated at 4.46. Hearing impairment was also found to be strongly associated with ED delirium, and after pooling the effect estimates of 3 studies with a total of 1,740 patients, the pool odds ratio for the association between hearing impairment and ED delirium was 2.57, where those with hearing impairment have a significantly higher risk of having delirium in the ED than those without hearing impairments. And lastly, here we found that a history of stroke, which is likely an indirect marker of brain frailty, was also strongly associated with ED delirium. And after pooling 3 studies with a total of 1,479 patients, the odds ratio estimated was 3.20. Okay, but what about the studies looking at the ED-based modifiable risk factors for developing delirium during hospitalization? So for this goal of our systematic review, we found 7 studies, including 2,238 geriatric patients who were free of delirium in the ED and who were then hospitalized and assessed for the development of delirium during hospitalization. And the overall incidence of delirium during hospitalization in these studies ranged from 11% to 27%. For this part of the systematic review, we evaluated 9 potential ED-based modifiable risk factors, but only 2 of them were found to have strong associations with delirium and a high level of certainty after evaluating the effect estimates with the grade approach. So an emergency department length of stay greater than 10 hours was significantly associated with a higher risk of incident delirium. And although this estimate came from one well-done study, including 330 patients, we had actually high certainty in this estimate using the grade approach, and the odds ratio for this association was 2.23. And the second most important risk factor for incident delirium that we found was also based on one well-done study that found a strong association between having severe pain in the ED and an increased risk of developing delirium later during hospitalization. And very interestingly here, this study, which came out of Canada, also showed that the administration of opioids in older adults did not increase the risk of developing delirium. So it seems that severe pain and not the administration of opioids per se is a key driver of new delirium that occurs during hospitalization. Okay, so to conclude, in this systematic review and meta-analysis, first, we found that nursing home residents, cognitive impairment, hearing impairment, and history of stroke were strongly associated with emergency department delirium in older adults. And also, we found that longer times in the ED and severe pain very likely increase the risk of developing delirium during hospitalization after being delirium-free in the emergency department. And we believe that these findings are critical for shared decision-making with families of older adults to perhaps to prioritize the screening process of delirium in the ED and for the development of future risk scores or prevention interventions. Thank you very much for your time and attention, and I'm happy to answer any questions.
Great, thank you so much, sir. We have one quick question coming from Moira Kennedy. How did you address age in the study? Some use it as a continuous variable, some use it as age cutoffs. Did you break it up in any way?
Yeah, so when we evaluated age, we evaluated as a continuous variable, but we actually use an approach that is not very often used, but we estimated the standardized mean difference, like a weighted mean difference, and then we transformed that into an odds ratio using specific methods. So we used as a continuous variable, but in the paper, we actually will report age as an odds ratio.
Understood. And then the last question from her is also in your talking about length of stay, was that the ED workup plus ED boarding time, or was that all inclusive?
So in the study that provided the effect estimated that I show, which showed that the more than 10 hours was associated with an increased risk, that study included the whole ED time. So including all the boarding time. And most of the studies looking at instant delirium, they measured the ED length of stay, including the whole time, so including the boarding time.
Got it. Perfect. Well, thank you so much. I think we'll need to move on because I don't know if it's going to automatically shut down. I want to move on to our last speaker, which
I'll try to answer the questions in the chat.
Yep, absolutely. Please.
Thank you.
Last one talking about this is Sam McDonald. He's from the University of Texas Southwestern. He's going to be talking about a randomized study to assess improving documentation complexity using a non-interruptive clinical decision support. Doctor, are you here, sir? He was here.
Are you able to hear my
Dr.
screen?
McDonald, are you all set? Yep,
Yeah,
there you are.
are you all seeing my screen or no?
I can see you, not your screen.
Okay, let's try that again. How about now?
Perfect. Yep, you're up.
All right.
And also, just to let you know, it has your slide, and then it also has your notes kind of coming up. So your new slide and post slide, which is still fine. There you go. Okay. Perfect. Yep.
I'll never figure this out. So I'm supposed to be the technical person, so I'll say. So the little change of scenery, and not a geriatrics focused talk, but a clinical decision support and documentation talk. So my name is Sam McDonald. I'm an informaticist and emergency physician at UT Southwestern. And there's a list of all the people that have worked on some with informatics and research kind of backgrounds that worked on making this study successful. We don't have any specific disclosures and no funding was received. One disclosure for y'all from me is that I'm not a billing expert by any means, but I'm the informaticist that kind of led the project. So a little background is anytime you talk about documentation, there's always negative sentiment towards it. And largely it's people saying, oh, I wish we just had T-sheets, or I wish we just documented the way we used to, where we just checked a bunch of boxes and kind of turned the paper in. And negative sentiment is really to focus on the EHR. And unfortunately, what people don't really realize is the EHR has provided a lot of value in care delivery and kind of value-based care that goes unrecognized when you're thinking about the amount of work burden. And a lot of times providers already feel so weighed down by the amount they document. When you ask them to kind of document certain billing specific things, they basically roll their eyes and don't do it. And I agree with them. They shouldn't have to. That's not their job. Their job is to focus on taking care of patients. But we want to optimize the use of the EHR to actually both benefit and reduce the work burden of physicians while still ensuring that the complexity of care is well documented. So we did a retrospective analysis, and we had a really large potential revenue loss from charts that should have been higher coded when due to inadequate documentation of some high risk medications and treatments. So our goal was to decrease downcoding of encounters with IV, intravenous or intramuscular medications, specifically Schedule II medications like pain medications and sedating medications. And our goal was to auto-populate a provider's note with coder relevant information at the bottom of a note, automatic, without any required intervention by the physician. And our hope was that by including a lot of this clinical context that often gets undocumented, that'll kind of push some of the charts from kind of a level 4 to a level 5 chart. And so how do we do this? We actually did this as a randomized study, and we let the EHR drive our randomization. And the EHR assigned a patient to either a treatment arm, which is the CDS intervention, or a non-treatment arm, which is basically just the standard note as it would have been received. We did this at a single site, our urban academic care facility, which is a quaternary care facility down in Dallas, Texas. And any patient where there was administration of that specific type of medication, Schedule II, IV, IM medications, was included in the study. And then our outcome was an ordinal variable, the final CPT code of that ED encounter. And we performed a simple ordinal regression the CPT code onto the arm assignment, so onto a dichotomous variable. And this was our intervention. Any time you talk about CDS, someone thinks it's going to be like this big pop-up red or yellow box that you have to click a button for. But this is a really very simple, kind of elegant use of CDS, where you have a rule-based method that if there's some sort of trigger, it checked the chart, looked for any kind of these specific medication administrations, and if it was there, it populated the note with a box at the bottom, that a space where almost no clinician ever scrolls down to. But the billers and coders, will kind of thoroughly go through looking for these specific features. This is kind of distribution of the results we saw. I highlighted some in red. I don't know what was happening when I was typing the abstract, but our total numbers was right, but the numbers assigned to the arms was off, and so I highlighted those. But pretty much our groups kind of the randomized groups were pretty equal, kind of suggesting a pro for using the HR to offer a simple randomized approach if people haven't done this. And what did our results actually show is that we found that there was a odds ratio about 1.57. And you may think, oh, that's not a huge impact. That's not a big odds ratio to kind of write home about. But for something with zero risk and only benefit, it actually shows some signal out of the noise, especially given that this is such a small impact medication choice, and it's such a small, for a pilot group, it's just a single intervention that we are assessing. And looking at kind of using that model, the estimated probabilities for each one of the arms, you'd have an 87% chance of having a level 5 chart compared to an 81%. So there was an increase that was found in our intervention arm. So what, I said this was a smaller intervention. This was a small one, but like zero impact to care delivery and only benefit from it. And what could this do generally if we actually scale this out to all different types of treatments and procedures and all the other documentation you do in the chart outside of the note? That should automatically get pulled in for and not have to be manually kind of written in by you for the coder's use. This would reduce documentation time. It will improve like attribution for the care that you do. A lot of times we do a lot of things that we don't get the benefit of. We don't get revenue generation for it, and we also don't help our health system by saying that improving our quality of care metrics. And then actually it will increase the time to provide actual care delivery. This is what we care about most of why we became doctors. We became doctors to go and care for patients and be with patients, kind of help them through what's bringing them to the emergency department. We didn't sign up to spend more time sitting at the computer. So we had some future work to expand and generalize this, increase the number of treatments that we include in this. And the long-term goal is to completely separate the clinical documentation from all the other documentation and try to optimize those use cases. And then I just put a little plug on the informatics side is the value of an informatician and the effective use of the EHR to one, from this project, improve documentation, but also reduce burden, improve physician wellness, and improve patient care long term. And so some final conclusions is the use of a non-interruptive CDS approach in our provider notes actually increase the complexity of care associated compared to our standard documentation practices. And then another plug for utilizing the EHR as a method for randomizing patients in clinical trials management was effective, free, and offered kind of with this study offered a balanced method approach. I'm happy to take any questions.
What was the actual small snippet that was added into the chart? What do you have an example of what that actually was?
Were you all able to see it? Let me see if I can.
Sorry, I might have missed it if it was there.
Yeah, it's really subtle. I mean, it's just this little piece. It's a box that pops up. It's collapsible. This is kind of what was entered in there. Any medication that would show up, it would sit right there.
So why did that add to the level of the complexity of the chart? What is that medicine specifically, or is it that
those types of medicine actually push your chart because the amount of work and kind of care delivery and complexity of care that's required for these medications that it pushes your billables up. This is what I've been told from our billing experts. So giving these high risk medications as long as there's obviously the appropriate documentation, your HPI and your other bill kind of content of your note, having these kind of characteristics in your note increase your complexity component.
Understood. And having it come in on the back end is nice because then you're not forcing everybody to use a canned note kind of thing that has to have all those different parts in there, which there has been pushback in a lot of places to say, this is our standard note, you must use it.
Right. So we actually do have I don't say required, but a really recommended. But what we do is we have two templates. We have a blank template that you can pull your note into, or we have our standard template, which everybody adopts because we do a lot of work on it, try to make it as kind of flexible as possible. But either way, if they use those two templates, this piece of CDS is already sitting in both of those templates.
There's one question from the audience here. Did any physicians notice the automated text and give feedback about it? And any possibility that they saw this and knew they wouldn't have to add information to their note? Yeah, so we kind of had that's kind of a little bit of a kind of an issue is we didn't have anybody. We told people that we were going to do this, that it would be at the bottom. And pretty much the notes, you don't really write in that note area. You write in kind of like separate sections that populate that note. And so people really aren't scrolling all the way down to the bottom of that note. But yeah, some people saw it. They didn't even pay any heed to it. Could you adapt this to other critical care time? Yeah. Meaning like if you put somebody on nasal cannula, direct patient care or any particular medicines that automatically populate a critical care attestation?
Exactly. So that's actually a future work for us we're actually, there are some critical care features that are very objective like this, blood transfusions or hyperkalemia treatment, insulin infusion, that will trigger some CDS. And then that would require an actual intervention because you have to say like, how much time did you deliver? What are the aspects of care you do? So we would use probably the standard maybe not always say interruptive, but one that requires some interaction with the clinician to provide components that probably isn't already documented, but would auto-populate the other things to support the critical care documentation.
Understood. What's the risk, however, that the coders and some of the Medicare and Medicare are just automatically going to brush this aside at one point, being that it's otherwise automated, right? Because technically, if you otherwise bring in some of the past medical history into your note and you don't click that you reviewed it, they may otherwise breathe over that you actually reviewed it, that you actually have to have an active move to review the past medical history for them to actually count it as something.
Yeah, so I think those pieces, and I'm not by any means a billion expert, but those pieces still require review. This, you're already doing the documentation for this in the chart. You physically ordered this medication. You have kind of gone and done your assessments of the patient. You know, other things are documented, but the fact that is that this medication is being said that it's been delivered and ordered and has these high risk associations with it that in the past have led to higher coded notes.
Awesome.
And this was just a kind of pilot case, and we really want to kind of hopefully scale it out. We'll see a lot bigger impact in our model.
That's awesome. I will open it up to any other questions from the gallery. If anybody else, please unmute yourself. Please make a question known.
Hi, this is Molly Jeffrey from Mayo Clinic, and I'm actually a researcher, not a clinician. So this may be a dumb question, but the purpose of this is really just to call the attention of your separate coders, your billing coders, to the fact that the intervention happened, because as you said, you know, the transfusion or the in future cases or the medication has already been charted.
Yeah, exactly. And so in clinical practice, you chart lots of things outside of the note, and then oftentimes the coders and the billers who are actually trying to get reimbursement for the care you provide get a really limited scope of that chart and what was done. And so bridging kind of some of the use of the EHR to pull in the aspects of care that you're already documenting elsewhere for compliance and just general care delivery gets pulled into a space where these billers and coders can see it easily to appropriately assign a level of care that was provided that is used to generate revenue.
Got it. Thanks.
Yeah.
Awesome. Well, thank you all so much. Thank you for our speakers. These were all really great talks, and I think there's a lot of great discussion. There's a lot more going on in the chat box in between some of the other ones. I'll leave it open for 30 seconds more for any final questions for any of our speakers, and I'd like to thank you all for coming to this session.
Thank you for moderating, Philip.
Yeah.
We appreciate the facilitation.
Not at all.
Yeah, thank you very much.
All righty. Thank you again. Congratulations to everybody, and enjoy the rest of SAM 21.